Well, hello everyone, and welcome. This breakout session is the importance of DEI work to address the social determinants of health. We are happy to be here with you. Just as a reminder, the focus of this panel is around the increased awareness of the importance of investments in diversity, in equity, and inclusion, and what that means within healthcare. We're going to talk about some of the efforts underway to collect better data around the social determinants of health to create a more inclusive healthcare workforce and connect better to underserved communities. My name is Jeremiah Rigsby. I'm the Chief of Staff at Care Oregon, and I'm joined by Courtney Kinney, who is from the Oregon. How am I blanking? Probably because I'm live on camera. OPCA, um, the Oregon Primary Care Association. Courtney is the Health Equity and Policy Manager, and then Tyler Tamir is with us also, who is the Executive Director of the Cascade AIDS Project. We're gonna start with Tyler and ask a high-level question. What programs or initiatives are you working on that focus on diversity, equity, and inclusion for your organization?
Hi there, everyone, and thanks so much for having me today. I am proudly serving every day as the person that gets to lead the team at Cascade AIDS Project, which is Oregon and Southwest Washington's oldest and largest community-based provider of HIV social services, and Prism Health, which is a federally qualified health center lookalike serving the LGBTQ plus community and beyond. By nature of who we serve, I think a lot of folks would imagine that we've been in the DEI game for quite some time, recognizing the stigma that has existed for people living with HIV since the inception of the epidemic here in the US, as well as the unique health disparities and often discrimination and trauma that LGBTQ plus people have faced in their healthcare. But just like everyone else, we have gone on our own journey with what diversity, equity, and inclusion work looks like at Cascade AIDS Project. I think like most organizations, we have had everything from a cultural competency committee that was planning trainings throughout the year to ensure that our staff had the foundational information and knowledge they needed to effectively do the work, to fulfill our mission, and to effectively serve the people that were coming through the doors for our services. But we, like most traditional aid service organizations over time, have had our own challenges and missteps with a variety of communities that have made folks hesitant to access healthcare. I think an issue that we've all had with communities that have very valid reasons for mistrust of healthcare over time. For us, I think that has really looked like being known as an organization that predominantly has served gay white men, and really needing to work on our relationship with communities of color and with the transgender community and women living with HIV, all folks who are facing HIV at disparate impact, but are not the regular faces that have come through our door. We've tried various things over time to try and improve those relationships, from staff committees to create work to become a more inclusive and affirming environment for both the staff that work at our agency and those that come through our doors. But probably the most effective work we have done has been in the last few years, really starting in 2019, when we hired an outside consultant to give us a very honest and raw look at how the community was perceiving our services, in particular, how the Black community in our region was seeing the way that our work was living and breathing in their day-to-day lives and in the communities that they accessed. That consultant did everything for us, from reviewing our policies and procedures through an equity lens to see if we were creating any unnecessary barriers that we just weren't aware of for our staff or the people we serve, assessed our baseline of knowledge on the history of Black folks in Oregon, the history of their healthcare in Oregon, the history with our organization, and the trauma that they may have experienced both in the larger healthcare system or perhaps throughout our history. We talked to former staff that worked with our agency that identified as Black and left within a 5-year period, to understand what their experience was and why they may have left over time. And did a series of trainings that many folks do, I think, when they dive into equity work around understanding microaggressions, implicit bias, and a variety of other really core trainings in this work. But probably the most profound thing that happened for us in 2019 was realizing that we needed to own the mistakes of our past, not just once, but in an ongoing way. And so in the summer of 2019, we released an open letter to the Black community from myself, validating the experiences that folks may have had with our organization over time, acknowledging the missteps that we have made as an organization, and committing to do better, but asking for help from the community. And in that work, we've begun to build stronger relationships with other Black serving organizations that may not be directly tied to our mission, but do have access, better access to the community. A great example of that is our Minority AIDS Initiative, which provides medical case management to Black folks living with HIV in the region. Instead of continuing to do that work internally ourselves, we worked to subcontract those dollars with the local Urban League of Portland, who has now an embedded employee on their staff that is serving the Black community in our region. They are helping us work on our relationship in serving Black folks, while we are helping them work on their relationship with Black folks who identify as LGBTQ+. And that work really laid the foundation for what changed greatly for us in 2020. I think as many organizations did in the aftermath of the murder of George Floyd, we had to take a hard look at what we were doing as an organization and how we wanted to show up further in this work. We had a really strong foundation in our commitment to being an anti-racist organization from the previous year, and very publicly speaking about what we needed to do better. But this was certainly the time where we needed to put our money where our mouth was. And we worked to quickly finish a hiring process for an equity advocate role at our agency, and to create a new equity fund that would allow our staff to invest in projects that were serving those communities most disparately impacted by HIV, but also work that may not be directly connected to our mission, but was important equity work happening in our community. All in all, it has been a tremendous journey as an organization. It's been one that has been very humbling, and one that is an ongoing learning process. And I think the biggest takeaway that I can share in my comments today is that everything that I have talked about in the time that I've been at CAP and the journey that I've helped to take our organization on in the 40 years that HIV has now been a part of our communities, all of this centers around trust. I think one of my earliest mentors really believed that trust encourages people to tell their stories and to help others. And as I talk about our equity work and journey at CAP, I often talk about how trust manifests itself in different ways. It's trust in healthcare, treatment, and science, trust in systems, in policy, and positions of power, trust in community, people, and relationships. But we also have to acknowledge that we've gotten as far as we have, continuing to make the same mistakes we have over time, because trust is also a currency. It's a two-way street that is going to hopefully and thoughtfully inform our decision-making and how we collaborate and do this work effectively in engaging communities that we want to serve and make an impact on. So I think that's the quick version of what we've been up to the last couple of years in this space.
Thank you so much, Tyler. That was excellent. We'll probably return to you. A reminder to those that are watching us that we have a chat function, so you feel free to submit questions, and we can get to those questions throughout our comments. I want to move now to Courtney with OPCA, and I want to make sure I got your title right, the Health Equity and Policy Manager for the Oregon Primary Care Association, OPCA. Courtney, has a shift occurred in how we view the importance of non-traditional healthcare services, like connecting patients and members to housing or transportation or food? And do you think that's a result of COVID?
Yeah, thanks, Jeremiah. So again, my name is Courtney. I'm the Health Equity and Policy Manager at Oregon Primary Care Association, and we're the membership association for Oregon's 34 federally qualified health centers, also known as community health centers. And community health centers, I think, have really long focused on social needs. I would even say that that's kind of the bread and butter of the community health center model. But the major shift that we've seen as a result of COVID, I think, is really a new momentum that has created more opportunity to understand and address social determinants of health across the system more broadly. And we know that the pandemic has made social needs more severe. And again, there's been that broad recognition that SUH has really driven the inequity of the pandemic. And we also know that social needs, of course, have direct impact on other health outcomes and on costs. But with more focus on SDOH, FQHCs, I think, mainly have seen that it's really increasingly important to be able to show the impact of social determinants of health on their patients with much more meaningful data and figure out ways to push for more flexibility in payment and incorporate that meaningful data into our payment models. So in June of last year, OPCA launched a year-long learning collaborative in an effort to improve data standardization, documentation, and sharing around social needs. And we did this with 5 FQHCs and 3 CCOs, really all in the western part of the state. And all of our participants had a really strong foundation in social needs screening and were able to tell us pretty quickly that housing, food, and transportation were really rising to the top for the patients in their regions. But throughout the year, they also raised a lot of concern around domestic violence and social isolation and internet access. And even with this kind of broad shift in momentum and excitement for addressing social needs, I think the pandemic also made it much more difficult to figure out how to innovate around that and exercise that opportunity. It made innovation around social needs screening and data sharing more complicated. It made referrals to community resources more complicated, especially as community-based services quickly became really saturated or unavailable altogether. And it also delayed higher level decision making because our clinics and workforce were pushed to absolute capacity. Roles were repurposed all over the place, from vaccination efforts to data analytics. And with all of this limited staff capacity, we also really needed to acknowledge that a lot of our health workforce were facing social needs themselves as a result of the pandemic. And with that came a lot of burnout and low staff bandwidth for these new projects. So that excitement is really important, but also it made things really confusing on the ground, and with clinics trying to figure out where they can focus the limited capacity that they had, which interventions would have the greatest impact for their patients, and which interventions funders wanted to see, and how can they continue expanding crucial funding for the work that they were doing. And all of this also linked to virtual care, this super rapid shift to the virtual environment that brought so many more challenges. How do we adapt social needs screening to be completed during virtual rooming, by mail, or in MyChart? And how do we do this keeping equity at the center when we don't have super culturally sensitive screening questions and our tools aren't translated into enough languages? And how do you translate an icon-based tool or a picture-based tool to virtual for patients with low literacy? And I agree totally with much of what Tyler said, and that 2020 really revitalized these calls for our health system to not only address structural oppression at the system level, but build trust with the communities that we have been leaving behind for a really long time. And social needs data sharing, right, is just another example of where that's super important. Clinics began to formalize the process for patient consent around sharing their data, recognizing that patients are way less likely to share if they know they're going to be stigmatized as that information is following them throughout the rest of the system as they're trying to access care in other locations. And I think that remains a really important question. We need this social needs information in the EHR to have accountable care, to address population health in a meaningful way, to achieve payment models that actually reflect the costs. But we're not going to get meaningful information if we don't keep patients at the center. And I think that this will actually continue to be more and more important as we start to incentivize outcomes over data, things like reducing hospital readmission rates or closed loop referral tracking, that we have to have these really formal ways of capturing patient preferences and what they're saying about the services that they're accessing, because we need to be sending them places that they feel really empowered and comfortable. So I think COVID created this shift with lots of challenges, but also I think we do have really strong opportunities ahead. Partners across the state are calling for a more dedicated workforce in a really united way. We want more traditional health workers. We want more dedicated roles. We want people looking at the data. Clinics and CCOs are exploring strategies to have rate parity for social care and incorporate social needs information into the existing risk adjustment models they already have. And billable services for SUH could dramatically increase our capacity to meet these needs. And then I would say finally, right now we have, I think, a really renewed commitment to community partnerships and reducing silos across the health system and investing in a much more meaningful way in community-based organizations. And from our FQHCs throughout this year, we've heard over and over and over that the most important tool that they have is community partnerships, and that the community-based organizations that they love, that are doing amazing work in their populations that they're serving, need to be well-funded so that they can get patients the resources they need. So I think we've become much more united around SUH, and it's really about how we use this new opportunity and keep that momentum going.
Thanks for that, Coordinator. Echo a lot of those sentiments around the community and the importance of the community. My question is something along the lines of, how do we improve the experience for people of color in the healthcare system, and do we look outside of traditional healthcare services to do that? And I'll get to that. I want to speak a bit to some of the things that my colleagues have said before. Care Oregon, at this point in time, we serve almost 500,000 people in the Oregon Health Plan. And we do that through our work with our CCO and the metro area health share of Oregon, and then Jackson Care Connect down in Jackson County and Columbia Pacific CCO on the North Coast. And this, especially since Medicaid expansion happened in 2014, I feel like when the coordinated care model really started getting its legs and running towards this academic idea of what we were supposed to do. And I think the secret sauce really is, you're supposed to be a health plan that adapts to the needs of your community. We started talking much more seriously about what diversity, equity, inclusion might mean, and really the last 4 years. But, as things happened over the last 2 years, we started realizing that what we were saying around diversity, equity, inclusion, and what we needed to be doing were different things, right? And diversity, equity, inclusion is such a broad term. I think I've said in forums like this before, it feels like if we say equity 3 times, well, at least we're now using an equity lens because we've acknowledged that the word equity exists. And in reality, for us, there are multiple levers that you would want to start thinking granularly about what equity, diversity, and inclusion means. Externally, that is culturally specific care. We're seeing a lot about the disparities that impact communities of color within the traditional healthcare model, which is what this question was about. That has been exacerbated through COVID, right? And that is really a different conversation when you talk about member engagement and populations that have not trusted this healthcare system, or the people that are saying, please trust us and come in and register for care, and we can meet some of your social needs and we can start doing screenings. I think academically, again, this system was set up, and this system is still run by, including our employees, people that are not eligible for the Oregon Health Plan for the most part, right? And this idea of community and who we are within this community, I think oftentimes comes off as these people academically doing things to the community and not doing things with the community. And that is something we've really been trying to internalize at Care Oregon. And I'll talk about that in a second. I think um, because diversity, equity, inclusion means everything from apologize. My dog cares about this too. It means everything from developing a workforce that has culturally specific providers or providers that are trained to work well with different types of population. It also means making sure you're bringing in marginalized groups that haven't been part of the healthcare system before. And it also means, we recognize it means who are you investing in as a coordinated care organization in the community? What does investment in community-based organizations mean? And in the last 2 years, we've also recognized that none of that is possible unless the staff internally are living and breathing this mission and have an idea of what equity, diversity, inclusion means in our day-to-day work and are supported in their education about what that means to them. And we at Care Oregon are recognizing a need to make sure there are resources for our staff internally to grow and to learn about each other. We're trying to set up employee resource groups. We've hired a chief officer of equity, diversity, and inclusion, standing back up our equity, diversity, and inclusion steering committee, and trying through our strategic plan to do more than just talk about equity, but to figure out what this work might look like in day-to-day operations within Care Oregon. That doesn't mean we've solved it at all. I think what we've done is stepped into the beginning of a conversation about how far behind we are. But because externally, whether it's with providers, whether it's with members, and very much under this yoke of centuries of systemic oppression, it feels like we have to pull each lever available to us when it comes to trying to move the needle. That means supporting proclamations declaring racism a public health crisis. That means supporting the Data Justice Act, where we're really trying to figure out how we can collect the right data on a population and update that data in real time to make interventions that are real and not just kind of have data sitting in warehouses that we're not using. I think that means investing in a behavioral health workforce and then going upstream from that and saying, how are we getting the providers we need in the right places? And that conversation is different in every community. So within the CCO space, it's important for us to be adaptable to what's available in the community, what the resources are, and make sure we get our members the right access at the right time, but also start pushing these other boats forward as we're trying to move the needle on what it means to be inclusive, what it means to have a diverse workforce. I think that some of the things we're proud of are things that we don't know the whole impact of quite yet. We're working pretty closely now with Portland Fire and Rescue in the Portland area to figure out how to get their community health assess team out there and talking to folks that are calling 911 and really they're calling 911 and they're not having an emergency. How do we get the right people to them to connect them to the resources in their time of need that are available based on the provider network that we're building? We're starting to put a lot of work in the traditional health workers. And that work is new for us, right? How do you bring community-based organizations in and have a multi-year conversation about making them part of a traditional medical model that we're literally trying to say this isn't the traditional medical model anymore, but we think that traditional health workers are the gateway into providing access to populations that have been outside of the healthcare system. We're proud of those investments, but I'm not here today to say we're expecting an incredible return on investment and that's our metric of success. I'm not here today to say that we hope to solve all the problems that have accumulated because of centuries of racism, because we're making some investments that look pretty good. I'm here to say I think moving the needle is looking at your community and saying, how do we work with you over the next couple of years, regardless of what we see, regardless of what the headlines look like, because a relationship is, I think, more important to us as a health plan right now versus a headline or a check we can write. These problems are so entrenched that it's much bigger than one grant, right? And it's much bigger than one community-based organization. And so I think we're trying to be on the right side of the population in ways that are different at Care Oregon and more based on relationships to the community. I don't think we've solved that. I don't think we do it perfectly. I think it's going to take time, but we want to be here to spend that time with the community so that the things that we're spinning up are what they have asked for, not what we think is best for them. So I'm going to stop there and look to chat a bit. We've got a few questions. I think we'll start with Courtney. the question is, why is there a focus on data when there's already so much data that prove that the social determinants of health and the gaps in care that exist?
I can throw in two cents here, and then I'm sure Courtney will have some to add. But I think what I would highlight first and foremost is that not all communities actually have had data collected about them. So we know about social determinants of health through a very specific lens. If you use COVID-19 as an example, early in the pandemic, we weren't even effectively collecting race, ethnicity, age, language, disability language across all areas of the state. We had to really work to ensure that that data was being effectively collected. And while that information was probably more readily being collected than others, things like sexual orientation and gender identity data were not. And there was a large movement to get that data collected, not only as a part of COVID data collection, but now through the Data Justice Act, which CAP is very proud of, leading the way on. We are excited to see that one day in the years to come, we will have effective data that will truly tell us about the impact of different health inequities across all different types of communities, not just the ones that the systems were originally built for and by.
Yeah, I agree with everything you said, Tyler. And then I would also, maybe circle back to some of the redesign things that Jeremiah was talking about, and that, yes, we know these things are true. We can see it all around us, and from on the ground experience to broad population experience, we know that these are the things that are impacting health. But right now, our health system is still really structured around this like very biomedical model of roles and of payment. And our system is still structured that way. And without meaningful data as it relates to cost and risk stratification for not only SDOH, but also race and ethnicity, SOGI data, all of the above, we can't effectively show how much we should be being paid to actually give our patients the resources that they need. So I think it is a little chicken or the egg. We know these things, but unfortunately, anecdotal information is not going to change the system in a meaningful way. And we need to be able to prove the true impact and cost of this for our patients.
That's right. My answer is going to combine it with another question, which is how can health plans address the social determinants of health and their members in a better way? And I think it's right. I know I just got done saying return on investment is a tough thing here. But I think in the health plan space, the thing that we do have, and I think the thing that obligates us more than not more, but in concert with our moral duty to this population, is the fact that we have an idea of what's happening in this population based on the data that we have, right? And we can track a little bit, as Courtney was talking about, what different social determinants of health interventions mean in the medical sense in the traditional way. I think at Care Oregon, one of the things that we've started doing is trying to recognize when projects or innovative projects come in, what part of this is going to have an impact on the community and is worth our time, and what part of this might be something we want to connect to our population health department and figure out specifically what it means for Care Oregon members. And then what does partnership look like in data sharing for that? So that we're watching over the long term exactly what Courtney was saying, what the things that you need in policy development that show change or progress. I think with the social determinants of health specifically, but more specifically with marginalized communities and communities of color, we need to be ready to spend some time, like I said earlier, to get that data back. I mean, there's a lot of trust building that has to happen. Really appreciate Tyler saying that and what trust means. And on a human, I mean, for us in the plan space, I think what we're trying to do is really be the humans that are empathetic and care about the members that we are serving. And it's hard to do when you're serving 500,000 people, right? And so how do you build trust with the community, person to person? You want to use your community-based organizations, and you want to allow time for those relationships to develop. And then we might get to a point where we're talking about alternative payment methodologies for a traditional health worker. We might get to a point where we're like, look at some of this data we got back, from this population based on this intervention. Might not have been in the year we thought we were going to do a pilot project, but because we stuck with community-based organization and build trust amongst that population, we may see some returns that are really beneficial that we might not have thought were possible. And I guess I say that because there's a lot I think that health plans specifically can show you that look great, look shiny, like really cool investments, and I think those things are a start. I think it's how you it's not just scaling up social determinant of health investments and figuring out how to hit a wide population. I think it's really what we're realizing is what impact is it having on specific communities, and is that trust being built in a long-term way within the community so that people will continue to work with you on projects, not just the first check you wrote in 2018 or something, right? So go ahead.
Yeah, I would also just add to that I think it's really easy for organizations and health systems to think of the things that are proposed sometimes by certain populations, or even in folks who are wanting to do this population specific work, that it's like a new way of thinking, or it's an innovative project, quote unquote. But often these innovative projects are things that are generations old within communities of color that they know are effectively working to help manage the health of that community who hasn't trusted the larger system. So it's a new way of thinking for the health system. It's an innovative project for that organization, but often I think it's about what we've been talking about. It's that building that lifelong trust and relationship. It's hearing from the community about what has been working, and in not making assumptions that communities that have traditionally been furthest from access and opportunity, that it's not often been by choice. It's been other barriers that have prevented them, and they have managed in other ways. And those things for them are not innovative. They are their way of life that have been passed down for generations.
And so to that point, actually, I asked my own question because we're learning about this and definitely do not have it figured out. And this question is going, I think, from me to Tyler, kind of in the vein of what you were just saying with the membership and what's happening in the community, is not new for the community. But I think, Courtney, the lens for you also is kind of burden on the provider network and on FQs. And the question is, like I said earlier, it feels like sometimes health plans can come in and just say, well, we're interested in doing this. We have a year. And we think this is good for you. Like, can you do A, B, and C? How do you have recommendations for how plans can come into the community and take into account, I think for your members, Courtney, the burden on providers to do screenings and what that means to collect data? And even though I think the provider network is wanting to move this ball forward, balancing what that means and making sure they still have the ability to see patients, to do the workflows they need. And then Tyler, I think on your side also, listening to the community is one thing, but really not coming in and supplanting the things that are working, but learning from the things that are working is what I think you're saying. Is any comments on what worked and hasn't worked from either of you?
Yeah, I can go. I think my answer will be fairly short, and it's really from the Social Data Sharing Collaborative, this learning collaborative. And the specific mechanism of data sharing that we were working on was Z codes. And we really liked Z codes specifically because they're tool agnostic. They don't require necessarily a strong foundation in specific tools or this lengthy workflow process. They're really adaptable, and they're really useful in just saying, we have this information about this specific patient. Let's get it in the medical record with the patient's consent and then figure out what we can do with it. And in that process, all of the clinics who are participating really proactively engaged their community advisory boards and patient advisory boards in figuring out, like, what is the script? What are the things that we should be worried about, and heard directly from their patients what questions they should be asking, who should be asking the questions, how should it be recorded in the electronic health record, what is a patient going to be concerned about, when they leave their primary care clinic, and this information follows them. And we learned a lot of really interesting things in smaller communities that are more rural. We learned that patients don't feel like they're ever really anonymous when they're sharing their social needs information. And we added we had clinics who added patient education around that and more trust building around that. We also learned that patients don't really love to be asked about social needs in really long formats or from people who haven't experienced social needs themselves, right? And so forth and so forth. So really taking those concerns seriously and engaging your patients in the development of the workflow, in the redesign, and taking that as expert knowledge in a way that I think our health system hasn't done super well. It tends to look up for advice and not in the communities that they're serving, right? So yeah, that would be my answer.
It's a beautiful answer. And the only thing I think I would add to it is a lesson from my own field, which has been, at the beginning of the HIV/AIDS epidemic, when communities of people who were dying and supporting those that were dying around them came together, they really pushed for this concept called GEPA, or greater involvement of people with AIDS. Through that movement, the Denver Principles were created, which were a set of guiding principles written by and for people living with AIDS in our country about how they wanted to see their access to healthcare and treatment options in the future. And ever since that time, people living with HIV and AIDS across our country have been fighting for a shift from GEPA to MIPA, which is meaningful involvement of people with AIDS. And, I think that we fall into this trap early on, and we need more people at the table to help guide our work. So the more people we have that reflect the communities we serve, the better. But if that work is not meaningful, then you're not really putting in that hard trust work that's going to build the relationship that will effectively then reach those communities in an ongoing way. And so I think it's figuring out, how do we not only get people to the table, but how do we get them there meaningfully? Engage, not only by listening, but being very clear and transparent about why we're at the table, what is going to happen to the feedback that they're providing, and looping back and telling folks, we heard you on X, Y, and Z, and we're not able to do anything about Y and Z, and here's why, rather than asking for this input and then folks feeling like their input was collected and not much was done with it.
Yeah, I think that's a great thing to call out, to being honest about what's happening with the input, and that it might not be rainbows and butterflies based on what the organization that can lead the table wants to do. It might be like, you need to explain to the community, though, exactly why or what is happening with how you're analyzing how they spent their time communicating with you. And so that's fantastic. A more specific question. Sorry, I was kind of getting into this conversation. Does anyone know where OHA is on changing their binary gender male-female data capture and availability of services? I know that in 2019, they only had options for male and female, and it needed to be gender assigned at birth, or you could get grouped in or out of services based on that. Is there any update on where OHA is at on that? I don't know the answer to that off the top of my head, unfortunately, so I apologize. I don't know if anybody else. No. We may need to circle back on that one. A more higher level question: how did the pandemic further expose health inequities? I might start. I think I mentioned this a bit earlier. I think we learned a lot, I think, about who we are as messengers, and trying to connect folks to information on what was happening during the pandemic, and then ultimately trying to connect folks to a vaccine. And I think, once again, it was a little bit of a lesson for our organization and what we think folks might want to hear, what we think might resonate with people versus what they've actually heard and how they're actually processing things. And we identified members, did high-risk outreach calls, and a lot of people were just like, yes, we know, we don't need you to call us to tell us to go do something that we know you all think needs to be done. And there were also people that were happy to get connected to services and referred to services. I think that was, so the takeaway for that was an inequity in communication, like in member engagement. Like, just, you think you have an idea what resonates based on what we've learned academically, but what resonates in communities is very, very different and nuanced. I think the counties have done a really good job. I know I've talked to Multnomah County a little bit about how they've brought people through the clinics that they have for vaccinations and how to get people engaged, and it wasn't what we were doing from the plan level. So I think the second thing I would say is, because of the shock to the healthcare system that the pandemic caused, and the delay of services, you really saw a lot of people who already felt marginalized from this healthcare system have health issues get worse and worse because of a lack of access, due to what was going on in the healthcare system and the availability of services. And I think we're starting to see a lot of numbers that show that that had a disproportionate impact on communities of color, especially those struggling with cancer diagnosis, et cetera. And again, it just exacerbating, I think, what we are all knowing, which is some of these stats have been entrenched in this healthcare system for some time. And it seems like the pandemic has exacerbated some of that as well. So turn it over to Courtney or Tyler.
Yeah, I guess from my world, we certainly saw what many organizations did. And I think Courtney mentioned earlier the increased need to address food insecurity, which was not a major part of our work prior to the pandemic, but certainly became a new line of work for us, ensuring that folks that were medically vulnerable, living with HIV or other chronic illness were stable in their housing. If they were not stable in their housing, that we were helping them through our ramped up emergency rental assistance program that already existed, but more than tripled in size during COVID to address those issues. We had folks who were too vulnerable to be living on the street during the height of the pandemic, but we did not have housing options for them. So we needed to work to coordinate medical motel vouchers and then figure out how to get them food in those motels. Also not a part of our work prior to the pandemic in a robust way. But I think beyond that, there is just this reality that even prior to the pandemic, we struggled to have things for various communities in an accessible way. So there are still populations that don't have accurate, up-to-date information about COVID in their native language that live here, that probably may or may not have access to the services that they need because they don't understand fully what's going on, or the information they have is passed down through their community in a way that has created additional barriers or potential barriers to care. And I think that only is a prime example of inequities that existed prior to the pandemic, especially for BIPOC communities and other communities that were facing homelessness, poverty, a variety of things that have just further been exacerbated by the pandemic.
Yeah, I don't have a lot to add to that because I think those were both really good answers. For me, I always think about, following that, like, how do we move forward then, right? Like, how, if the pandemic has further exposed these health inequities, and despite our workforce challenges, if the pandemic has also shown us how adaptable our health system can be, then how do we approach these other broad challenges with the same level of fortuitiveness and adaptability and funding that have really deserved that level of focus for a long time? So systemic racism in our healthcare system, chronic health conditions, people experiencing homelessness, all of our specific populations that we know have had this worse and whose challenges have been exacerbated by the pandemic. How do we now give that the same level of focus that we gave COVID? And I think that's a really important question. And I think it's an exciting one right now with all of this new momentum, but we really need to keep that going and decide what our next focus is.
All right. Well, I think this will be kind of the last question. I think we're at about 45 minutes, and it was aimed at Care Oregon, but I think it's more of a question about the behavioral health workforce and equity within the behavioral health workforce. The question was, what is Care Oregon doing for those struggling with ACEs, that's adverse childhood events, increases in depression, violence, but cannot access mental health services due to the shortage of providers? What does equity look like for access to behavioral health services in this time of crisis? I'd say from the health system space, at least for Care Oregon, I think what parity means in the behavioral health space is something that we've been talking about for a long time. I think the coordinated care model, one of the pillars of the coordinated care model, is integrating behavioral health, physical health, and oral health. And I think what we are finding out right now is how thin the definition of integration means when it actually comes to the impact on the member. And that's wholly dependent on a workforce that has been in over the last, since time immemorial. And I think it has all come to a head at a time where our state hospital is struggling with capacity issues. Our state is small, and the community resources have become more and more slim. I think there's a call to action to improve the behavioral health workforce in any way that's possible. Care Oregon made a $7 million investment in the community to behavioral health providers, and it's a drop in the bucket for a provider network that is stretched to its breaking point, that has been, again, underinvested in years. And I think we're recognizing that there are things that we are going to need to work on with both the legislature and with the state agency to figure out what sustainability looks like for a workforce we are wholly dependent on, but have been relying on in a way that was not equitable. That's all separate from, I think, a conversation about getting the right culturally specific care to communities that are struggling with behavioral health issues at the right time, right? And so I think there's a crisis, and there's a crisis in bringing the right people into the system with the resources that we have. And it feels like it is investment from plans. I think it is advocacy with the legislature, and I want to say thank you to the legislature for the behavioral health package that was passed in the 2021 session, which is an unprecedented investment. But now the work is with the agency to figure out how that money gets to the right place. We have all the money. What do we do now to make sure the policy has an impact down on our members? I'll stop there because I know we're short on time, but it's a big question. I don't know if anyone else has anything to add. Okay.
I think the only thing I would add to that is, I think we all know and recognize that if we added 5 to 10 new mental health providers today, their panels would fill up overnight. The issue is much larger than we can address in a single day or even a year, or with a one-time or even multi-year investment. So being thoughtful about how those dollars are being spent and ensuring that we're creating the spaces that folks that traditionally haven't had access to behavioral health or have been hesitant will come to. I think an example for my agency, Prism Health, as a federally qualified health center lookalike, we're looking at as a very result of the last 18 months, we're looking at an expansion site in a more traditionally Black neighborhood to try and figure out how we can add to the behavioral health services already being offered in that area, but to ensure that it's more accessible than our current location may be for traditionally Black and Brown communities. And for us, we know that those panels will still also fill up quickly, but we believe by moving services closer to that community, we have a better chance of serving those who might also have other impact on their health.
Yeah, I would agree with that. I think it's really, moving forward, it's really about the idea of redesign and thinking about who our behavioral health services are trying to reach and who has the highest need, and designing services to suit those populations. And I think as we talk about social determinants of health and systemic racism, I think it will be really important to continue to look at where those impacts compound. I think behavioral health is a really important space there. I think visit no-shows, who's not showing up to our brick and mortar sites, that's a really important question. I think adding substance use into those formulas is a really important thing to add. So as we start to redesign our services to be more integrated and be more nimble and more data-driven and more focused on equity and who has the highest need, all of these things intersect, and we have to look at them as the complete package that they are, and adapt all of our services to be very comfortable and nimble to that.
Great. Well, Tyler and Courtney, thank you so much, and thank you all for watching. I believe this will be recorded, and I think we got to most of the questions in the chat. We're right at 12:50, so thank you all for spending hopefully your lunch with us, and talk to you soon.